good evening, and thank you so much for joining us. Welcome to our quarterly webinar series hosted by the ASRM Ethics Committee. My name is Judy Dar, and I have the privilege of serving as chair of the committee. In my day job, I'm also the dean at Whittier Law School. Today is an exciting day for us because it marks our first webinar in the second year of our programming. And we're just delighted to bring this programming to ASRM membership, which has been very popular, and we're very heartened by that. Today's speakers will share with you their perspectives on the provision of infertility care to patients who present with serious conditions that pose risk to themselves and potentially their offspring in the course of either treatment, pregnancy, or both. This topic is something that the committee has been wrestling with now for a couple of years and is the subject of a brand new ethics committee opinion, which is published in Fertility and Sterility, with two of our speakers today having been very essential to the drafting and refining of this document. So let me talk to you about the three speakers today, a bit about what they're going to present, and again, a small amount about their amazing backgrounds. Starting with Dr. Sigal Klipstein. Sigal's going to speak with us about fertility services for women at increased risk. Dr. Klipstein is a graduate of the University of Chicago Pritzker School of Medicine. She completed her fellowship in REI at Boston IVF, as well as a fellowship in medical ethics at Harvard Medical School. She's currently in private practice at India Fertility Specialist in Chicago, and is also a clinical instructor at the University of Chicago Department of OBGYN, where she teaches medical students and residents. Dr. Klipstein currently chairs the ACOG Committee on Ethics, which is what brings her to us as a liaison from ACOG, and she's been an incredibly wonderful and valuable addition to the ASRM Ethics Committee. Next, we'll hear from Dr. Neil Silverman, and he'll speak with us about approaching the medically complex pregnancy, who decides. Dr. Silverman practices at the Cedars-Sinai Center for Fetal Medicine and Women's Ultrasound in Los Angeles, where he provides consultative care for high-risk obstetric patients. He's also a clinical professor in the Department of OBGYN, the Division of Maternal Fetal Medicine at the David Geffen School of Medicine at UCLA. He served as the Publications Committee Chair for the Society for the Maternal Fetal Medicine Division of the MFM Society, and he also is a liaison member to ACOG's Committee on Ethics in that capacity. So welcome to Neil. Then finally, Professor Leslie Francis will speak with us about fertility services for women at increased risk, ethical considerations. Leslie holds joint appointments in law and philosophy at the University of Utah, where she also serves as the Associate Dean for Faculty, Research, and Development in the College of Law. In addition, she directs the Center for Law and Biomedical Sciences at the law school. Leslie teaches and writes extensively in the areas of health law, bioethics, and disability. In 2014, Professor Francis became president-elect of the Pacific Division of the American Philosophical Association, that organization's highest academic honor. Professor Francis is also a member of the ASRM Ethics Committee, and again, I might say an incredibly important and vital one to the services that we provide and to our mission. So welcome and thank you so much to all three of our terrific speakers. Jessica mentioned a few housekeeping notes, and I'll just add mine as well. Each speaker will present for roughly 12 to 15 minutes in the order that I've just introduced them, and they'll walk through their PowerPoint slides and talk with you about each slide. We welcome questions at the conclusion of the presentation, and you can type your questions into the chat window in the bottom of your gray toolbar, which should appear on the right-hand side of your screen. We encourage questions, and we'll answer as many as the time permits. And just a programming note, if I may plug our next webinar, we're going to be speaking in December about emerging challenges in gestational carrier arrangements. We have confirmed 3 speakers, and we will be letting everybody know about the date. So thank you for this time. And I'm going to turn over the presentation to Sigal.
Okay. Hi. Thanks, Judy, for that wonderful introduction. The portion of my talk will be titled Strategies for Assessing and Managing Risk in Assisted Reproduction. And I wanted to start by saying that, in general, women expect that at the end of their pregnancy, both they and their newborn will be healthy. In general, this is true, and this is a graph of maternal mortality in the U.S. It's fairly low at 28 per 100,000 women. Unfortunately, and somewhat shamefully, the number is rising in the U.S. That's the black line compared to the blue line, which is the decrease in maternal mortality in the rest of the developed world, but hopefully we will work on fixing that. But still, nevertheless, the level stays fairly low, and 28 per 100,000 women, while we would aspire to 0, nevertheless, most women can expect to be healthy at the end of their pregnancies. Similarly, the neonatal mortality rate is low at 4 per 1,000 infants, and so then most women rightfully assume that their babies will be fine at the end of their pregnancies. Having said that, there are some women at increased risk. And the questions I want to pose are, how do we identify these women? What are the options for treatment of these women? And once we identify them, how do we optimize their care preconceptually and during pregnancy? And so let's start with how ART is different. In reproductive endocrinology, women, of course, present preconceptually, and this puts us as physicians in both a privileged and, I would argue, a challenging position to assess the risk of pregnancy prior to its initiation. We all know that women can come with pre-existing risk. They may be older, they may have underlying disease, and we as reproductive endocrinologists have a range of reproductive options. Certainly we can offer traditional treatments like IUI and IVF, consideration of third-party reproduction, both with donor gametes, and in our case, when we talk about risky IVF for the mother, gestational surrogacy to obviate those risks for her. And then, of course, something that I want to come back to again and again in the talk is that it is also an option to not provide treatment, to decide that the risk is so high that perhaps treatment is not warranted, either at the decision of the mother or in the risk assessment of the physician. So what are the types of risks? There are risks that arise from the treatment itself. So we know that some women have increased risk, for example, of ovarian hyperstimulation if they have high AMHs, or they're very young, or they have polycystic ovarian syndrome. Certainly risks of multiple pregnancy, which can be very much controlled in IVF, but in ovulation induction that still remains a risk. And then things such as thrombotic events. Then there are risks due to underlying conditions, whether that be chronic or genetic, and there are relative risks and absolute risks. So for example, hypertension, diabetes, chronic illnesses, a lot of women come with these, and these are in general manageable and increase their risk, but aren't reasons to decline treatment or to think that a pregnancy is so dangerous that the outcome couldn't possibly be a good one. Then there are other things such as, for example, peripartum cardiomyopathy, where the risk of death in subsequent pregnancy is quite high. And I wanted to spend a few minutes a little bit later on talking about Turner syndrome, which I think is a little bit of a special case for our field. And then the risks can be divided into modifiable versus fixed. So for example, weight, smoking, blood sugar, all of these in general are modifiable, even number of embryos transferred, amount of gonadotropins used in IVF. But then there's some women that have underlying disease. Obviously, you can't change the disease that you're born with if it's a genetic disease and so on. So some of these are not modifiable, and there's not much we can do other than manage the risks. Of course, everything starts with assessing the patient, and patients should be assessed for risk of complications from both the treatment and the pregnancy. And importantly, this should start at the first encounter, but the risk assessment should continue as the woman progresses through the planning stages and the treatment of infertility, as well as the pregnancy, of course. Central to risk assessment, and the next logical step is counseling. So the reproductive endocrinologist certainly plays a critical role in assessing health and should really lean very heavily on the many resources available to him or her. For example, maternal fetal medicine, and Dr. Silverman will speak to the benefits of referring to a maternal fetal medicine expert and all the things that can achieve is really critical. And some of the patients will come already with underlying diseases who already have their specialists that they see. Others will not yet have specialists, and coordinating that care and benefiting from the expertise of others is certainly helpful and will lead to better outcomes. And then once the issues have been assessed, the patient really needs to be thoroughly counseled regarding her risks and the ways to mitigate these risks when mitigation is possible. And this may actually be a really good time to discuss other options to IVF, third-party reproduction, and again, the option of not undergoing IVF. It is okay to recommend against treatment. Physicians may decline to offer services requested of them when they deem the risk to the patient or the pregnancy to be too high. Now, not all pregnancies will be perfect, and not all outcomes will be optimal, and so when declining to treat patients, one really needs to be aware of their own bias or potential bias. Fertile couples who choose to weigh the risks and benefits of pregnancy can choose to become pregnant without any outside counselor assistance, and we really need to be careful to compare the situation to spontaneous reproduction and not to any idealized view of what constitutes a perfect pregnancy. Certainly, reproduction is a basic human right. Some individuals and couples may not be able to reproduce or may need help in doing so, and the infertile on some level are already disadvantaged by virtue of their infertility. We should really work to not have them be secondarily disadvantaged by discriminating against them. So this sometimes leads to conflicting autonomies. On the one hand, you have the right of the patient to create a family, and on the other hand, you have the right of the physician to refuse when the harm outweighs the benefit. And in these cases, especially when a physician is considering refusing to provide treatment because of the risks being deemed too high, he or she should strongly consider referring the patient for a second opinion, certainly to make sure that the decision is not stemming from some unrecognized bias, and also to make sure that there's some consensus from experts. There's a full breadth of experts, both within OBGYN and beyond, and also one can refer to reproductive endocrinologists just to make sure that the decisions are not steeped in any type of bias. So I wanted to spend a little bit of time talking about Turner syndrome because I think it illustrates a few of the concepts of what is a risky IVF cycle. Of course, these women in the vast majority cannot conceive without an egg donor, so the reproductive endocrinologist is intrinsically involved in their care. And the risk of maternal mortality in a woman with Turner is 100% increased over her baseline risk. And the biggest risk is from aortic dissection and rupture. And interestingly, the morbidity and mortality may persist well beyond the pregnancy. And so the question I pose is this a relative or is this an absolute contraindication to pregnancy? We all know that there are women with Turner syndrome who have used donor egg and had perfectly healthy pregnancies and good maternal outcomes, but not everyone. And so what's the role of the reproductive endocrinologist? Certainly to facilitate consultation, this can be with maternal fetal medicine. In the case of Turner's, it's very important also to refer to cardiology for echo, cardiac MRI, to decide and to delineate these underlying risks. And then also any discussion of egg donation in a woman with Turner should also discuss risks of aortic rupture and risks to pregnancy and include alternatives such as gestational surrogacy, adoption, not pursuing child-free living. And it's interesting because this is one of the few places where ASRM's practice committee really weighs in very heavily with a recommendation in terms of declining to treat. And I quote, cardiac MRI revealing any significant abnormality and/or an aortic size index of greater than 2 centimeters per meter squared represents an absolute contraindication for attempting pregnancy in a woman with Turner syndrome. And even women with normal cardiac MRIs still are at much higher risk for associated morbidity and mortality and should be continually assessed. So I leave that as, I guess, a strong warning to consider very heavily whether to offer treatment or not in these women, considering the very high risks. There are other cases in which the risk to the patient also confers risk to the child, and this occurs, for example, in Ehlers-Danlos, particularly in the type 4 vascular form. And this is, as we all know, an autosomal dominant disorder in which 50% of babies will be affected, or 50% of offspring will be affected. The risk of maternal death is quite high, 6.5%, and this is a disorder of faulty collagen, so not only just in the skin, which is obviously stretchy, but also in the muscles, ligaments, and organs. So the risk here, similar to Turner's, is of aortic dissection, but also there's risk of uterine rupture, and of course, obviously risk to the pregnancy if that happens. So what are the options here? You can avail yourself of preimplantation genetic testing to avoid the risk to the child. And then, of course, a gestational carrier would avoid the risk to the mother and also the risk to the pregnancy, obviously, if there's a uterine rupture or any other type of uterine weakness that can confer risk to the ongoing pregnancy. So then what is a physician to do when faced with a patient who is identified as having higher than average risk for complications to her or her pregnancy during treatment or pregnancy? Referral is an option that should be used quite liberally. When the risk is higher than average, strongly consider, of course, referral to maternal fetal medicine early in the process, as I've said, consultation with a specialist in the patient-specific disease process, but also kind of early pregnancy planning. So the patient, in most cases, should plan on delivering in a tertiary care center with facilities in place for their particular disorder. In the case of Turner's, for example, you want to make sure that the cardiologist is on staff at the center where she will be having her baby. And then also, to err on the side of caution, you do have the luxury of time when the patient's not yet pregnant. And so you can defer treatment, you can delay treatment, and there's some unique options. So for example, you can wait until consultations are in place, you can wait until the modifiable risk factors have been addressed, whether that's diabetes or hypertension. And then in some cases, we have this extra benefit of being able to perform IVF but not transfer. So for example, if a woman comes in and she has a molar pregnancy and she's recommended to wait 6 months until her HCGs are negative for 6 months before she conceives again, one could perform an IVF cycle, especially if she's a little bit older and you're worried about fertility decline with age, and you can delay transfer for 6 months or a year, and yet not risk the declining ovarian reserve over that period of time. So what are the challenges to the physician? Of course, whom to treat, when to decline, when to refer to a specialist. Certainly preconception counseling and disease management are important pieces of the puzzle. And then where does the risk lie? Certainly to the pregnant woman in most cases. Often if the woman is unhealthy, then her offspring or her pregnancy can suffer. And then something we don't often talk about is the partner who may remain a single parent, or the children who may lose a mother to disease or have a mother who is less healthy after a pregnancy. So all these things are challenges and considerations. And then just in conclusion, all fertility treatments, and we have to remember pregnancy in general, confers risk to the woman, and women should be assessed for their level of risk early and often. And then when risks are increased, certainly counsel, refer for consultation, optimize health, consider the location of delivery, and always consider alternate options, including the option of no treatment. So thank you, and I will turn it over to the next presenter. I'll be happy to take questions at the end. You can send them anytime through the chat window. Thank you.
Good afternoon, everyone, and thanks to Judy and the folks from ASRM for asking me to be part of this webinar. I am going to deal a little bit more with sort of augment Sigal's great talk and hopefully give you an MFM approach toward this. I'm going to start by discussing a little bit about ethical principles, since this is an ethics seminar, and rather than a full review of all of the standard principles of ethics, which include things like autonomy that was addressed and beneficence and justice, I think that the major focus of this talk really deals with non-maleficence. So our goal here, as we counsel people about planning to get pregnant, is really to do no harm to the woman attempting or considering a pregnancy, and understanding that promoting the patient's well-being or beneficence and non-maleficence do work together, and that really describes the concept of balancing risks and benefits in every treatment decision we discuss with patients. In this brief presentation, I'm going to discuss these medical issues, primarily maternal age, advanced maternal age versus either very advanced maternal age or advanced reproductive age, depending on which society we read. Also talking about multiple gestations, trends and cautions, and then the concept of avoiding increasing medical complexity. As a little bit of background, I just want to do a brief review of what the national data tell us about the rates of medical conditions in certain populations. These are drawn from data last released in 2013 from the CDC, and this slide demonstrates age-adjusted prevalence of hypertension and blood pressure among adults, high blood pressure and control. And what I'm going to highlight here are the issues related to sex, where there are comparable rates of hypertension but lower rates of blood pressure control among men overall. But when we look at age groups, we can see that just Our baseline adult population in the U.S. has a substantially higher rate of hypertension and only about a 50% rate of blood pressure control before getting pregnant. So we're talking about a population of individuals who have increased rates of hypertension and lower and modest rates of control at best. And then when we look at death and age-adjusted death rates from individuals with coronary heart disease in the general population, we can see that in the age group 45 to 54, there are substantially higher rates of these adverse outcomes compared to the population from 25 to 54, almost a 7-fold increased risk. And then when we talk about folks over 55, the rate doubles further to about 130. When we talk about pregnancy and maternal age, these are issues that are in the popular press, and these are patients that we deal with on a regular basis. And the primary issue of concern is what has been defined by Gary Dildy in the late 90s as very advanced maternal age, meaning women who are at or older than the age of 45. In the United States, between 1970 and 2006, the percentage of first births in women over the age of 35 increased 8-fold. In other countries, for example, in Israel, that rate went up 230%. And these increases followed landmark studies almost 25 years ago now that described successful pregnancies in women above the traditional reproductive age using oocyte donation. So egg donation became a major adjunct to offering assisted reproduction to women over the age of 45. But what's been shown is that very advanced maternal age has also been associated with increases in adverse pregnancy and obstetric outcomes, as well as increased expenses in health expenditures. Now, there were smaller series reported earlier, but larger series of very advanced maternal age pregnancies have been described in the past 5 years. You can see here from a study published in just a couple years ago that the total number of births here in blue and green, the left graph looks at the total number of births, and you can see that it has increased up till 2010 in women from 45 to 49, and similarly increased but at lower rates in women 50 to 54, and the total birth rate has increased gradually but consistently from 1980 to 2010 in women 45 and older. 2 recent series came from Israel and Australia. These are larger cohorts of women with very advanced maternal age that importantly were compared to control groups of women 30 to 35 for outcome comparisons. An Israeli study was published earlier this year in Maternal Child Health Journal. They showed that 95% of these pregnancies in women over 45 were through in vitro fertilization, with 80% using younger oocyte donors. But it's important for us to keep in mind and to counsel our patients that the age of the oocyte donor does not lower the perinatal risk for women over the age of 45. It is still the maternal age. And at 40% of women in this Israeli study had at least one chronic medical condition predating the pregnancy. In the Australian study published 3 years ago, there were over 200 women studied over the age of 45 and over 4,800 women between 40 and 44. And in this study, it was maternal age, not the use of ART, that was associated with an increased risk of preterm birth. And there were lower rates of women with pre-existing medical conditions like diabetes and hypertension. These are data from the Israeli study, and specifically I think it's important to see that there were significantly higher rates of gestational diabetes, gestational hypertension, and preeclampsia and eclampsia in women over 45 compared to those 30 to 35, and as well these women were much more likely to have at least one pregnancy complication, almost 3 times as likely to be hospitalized during the pregnancy, and had much higher rates of preterm delivery. 25% of them had deliveries under 37 weeks. They also were much more likely to be delivered by cesarean section. In terms of neonatal outcomes, we can see that in this group of women over 45, they had higher rates of low birth weight infants and higher rates of neonatal jaundice and hypoglycemia. A more recent study was published by a group out of Duke and the University of Virginia and University of Pennsylvania, published in 2014. And what's important statistically is this was a very large national data set, and they stratified the older groups and compared them to younger women. You can see here that there were over 10 million women in the database under the age of 35, 1.8 million between 35 and 44, and almost 24,000 over the age of 45. And we can see that when we look at heart disease, these women, the women who were over the age of 45, had significantly higher rates of most of the medical complications of concern compared not just to the women under 35, but compared to the women 35 to 44 as well, our traditional advanced maternal age group. In a summary, an adjusted odds ratio, there were higher rates of medical and obstetric events at delivery in this over 45 age group compared to our traditional advanced maternal age group, and compared to women under 35, 10 times higher rate of maternal death among women over 45, 21-fold higher risk of MI, 10-fold higher risk of cardiac arrest, 5 times higher risk of pulmonary embolism, higher rates of thrombosis and acute renal failure, and as well higher rates of adverse neonatal outcomes like growth restriction and fetal demise. Multiple gestations are an obvious concern when we talk about implications of assisted reproduction, and traditionally these were spontaneous multiple gestations when we talk about quintuplets, for example, but more recently we have popular press talking about women who are over even 50 or 55 having multiple gestations, and I think it's important that we understand the potential implications of these issues. Now, the good news is that in recent data reported from the CDC earlier this year, we can see that after a peak in the early 2000s, our rates of triplet pregnancies, for example, have significantly decreased and continue to decrease, so that reflects the fact that in ART procedures, people are adhering to guidelines recommending a reduction in the number of embryos transferred, and that has really been a primary contributor to the decline in higher order multiple births. But we still see that in women 45 and over, there are still substantially higher rates of higher order gestations compared to younger age groups, even 40 to 44. The percentage, so while the percentage of higher order gestations has decreased, the percentage of twins has increased, and it's important to keep in mind that the majority of high order gestations have actually resulted not from IVF or natural conception, but from ovulation induction and superovulation, so that strategies for ovulation induction in anovulatory women should continue to use the lowest doses possible with the goal of ovulating a single oocyte, and this is an ongoing message that ASRM itself is trying to get out, that the goal of infertility is one healthy baby at a time. So are there individuals who actually, for whom even a twin gestation would be a detriment? And the medical literature demonstrates to us that there are some clear categories for which a singleton is absolutely preferable from a medical point of view. This includes women who have prior preterm birth, women with known uterine or cervical abnormalities, and some maternal medical conditions that are not uncommon, like a history of preeclampsia, which is a placentally mediated event, so we want to minimize the number of placentas present. Women with underlying renal, cardiac, and sickle cell disease, for example, and some are beginning to question whether women of over the age of 45, very advanced maternal age, may not be benefiting from having multiple gestations in general. People have looked at fetal reduction as a solution toward minimizing risks in women who have unexpected multiple gestations, twins, or even higher order gestations. So it is true that reducing fetal number can lower perinatal risks, primarily the risks of prematurity, but studies have demonstrated that lowered rates of obstetric complications, for example, triplets to twins and twins to singletons, are not the same as those for pregnancies that start at the lower order. So a pregnancy that has been reduced from triplets to twins may have lower risk compared to triplets, but not the same risk as natural twins. And there may be some early pregnancy programming going on from the placenta that still continues even when the pregnancy is reduced in the late first or early second trimester. And fetal reduction still does carry with it an increased risk of procedural loss. So some of the recent outcome data that have been reported out of the Netherlands and reported a couple years ago show that triplets, they looked at spontaneous triplets and spontaneous twins, and then a reduction group from triplets to twins. And you can see here that the reduction group clearly has a higher gestational at delivery for those remaining twins compared to triplets, but not as far along as spontaneous twins would have gotten. And the mean birth weight and rates of delivery under 32 weeks are still in that middle range. And similar data are reported when we look at twins that are reduced, twins that are not reduced, and singletons, that deliveries less than 32 weeks are still higher compared to spontaneous singletons, and gestational age of delivery is still not the same as a natural singleton pregnancy. So while reduction is a good option for reducing risk, it is not the same as we will not be producing the same risk as a natural pregnancy that started that way. Finally, I'd like to counsel people regarding the possibility of overcomplicating medical issues for women who are anticipating pregnancy with pre-existing conditions and cautioning against making these issues more complicated. Despite good intentions, we sometimes see our referring physicians as MFMs making conditions worse. Sometimes we see undertreatment of common medical problems, so that women who are well maintained on antihypertensive medications either are counseled that their medication should be stopped, or they're swapped out for clearly less favorable, less effective antihypertensives like methyl-dopa, which no self-respecting internist would start a patient on who wasn't pregnant to begin with. And while its safety profile may be well established, it's clearly less effective than approved medications in 2016. Similarly, we see people who are not adequately counseled, as Sigal mentioned, about maintaining appropriate glucose control prior to assisted reproduction of any kind. We also unfortunately see empiric discontinuation of some chronic medications. The most common categories of these that we see are psychotropics like antidepressants and ADHD medications, which for the most part can safely and should be continued through pregnancy, antiepileptics, and autoimmune medications like corticosteroids and biologics. And it needs to be kept in mind that these medications actually frequently need to be increased in dosing with pregnancy because of metabolic considerations. Our goal ultimately should be to work together to optimize perinatal outcomes. A singleton for complex pregnancies is usually the optimal goal. In very advanced maternal age women need to understand that the genetic risk and the maternal risk for a pregnancy are frequently different, and that whether conception is natural or assisted, patients at increased risk deserve targeted counseling before pregnancy, and a preconception consultation with a patient's internist or a maternal fetal medicine specialist is frequently helpful in crafting an informed plan across disciplines for potentially complex pregnancies. It is okay to use a lifeline and to phone a friend and to consult other colleagues from ACOG and the Society for Maternal Fetal Medicine. So that's the end of my part of this discussion, and thank you very much.
I want to start by thanking ASRM for the enormous privilege of having been a member of the ethics committee. It's a wonderful committee to work on, great colleagues to work with, such as Sigal, and to meet such as Neil. So my goals today are going to be to say a bit more about some of the ethical considerations. You've already heard from the previous speakers what some of them are, and to present to you the recent ASRM Ethics Committee opinion. So one of the most difficult features of these situations is that the patients who present for IVF who are riskier are making the choice that, at least initially, to come for the consultation about something that is deeply important to them. These are women who very much want a child. They're also women who are, in many cases, in a situation that's just like other women, except for their infertility. So they're likely to be very much aware that of the irony that if it weren't for infertility, they could take the risk on their own. Now, I say here on the slide, this raises questions about the limits to choice, because other people might be able to make these choices on their own. But there are very serious reasons to be worried about the choices that women might make in these circumstances. First of all, the intensity of the desire may cloud thinking. Secondly, we're aware of cognitive biases, one of them being the thought that risks just won't come home to roost, that bad things are going to happen to other people, it won't happen to me. This is also an area in which there may be serious pressures from family members or from members of a woman's community that affect the level of voluntariness of her choice. This means that for physicians, the counseling process is likely to be very complicated in these circumstances. One of the things I would emphasize is the importance of working very hard to understand with the patient what her actual goals are. There may be some women for whom the experience of pregnancy is critical, but more likely, many of these women are going to be women for whom there's a strong desire either for a biologically related child with her partner or for a healthy child. And talking through whether those goals are really achievable in her circumstances is absolutely critical. Now, another irony in these circumstances is that while surrogacy may be an option for some women, it's possible that it will also be out of economic range and certainly not covered by insurance. Another complication that I think practitioners need to be aware of is that some of these women may not want to share the full story about their risks with their partners. It may be in part because they are concerned that their partners will discourage them from going through with a reproductive project, or it may be that their partners would not want to go through with a reproductive project if it's that risky. One of the things to talk about here with a patient is that not having her partner know may actually increase the risks, particularly if she gets into trouble and there isn't someone around to help her. Another issue to consider here is what kinds of risks are of concern and to whom. Some of the risks are risks of physical injury or even death to the patient. Some of them are risks to the unborn child, and these might be not only physical risks, they might also be the emotional risks of being raised without a parent. Some of these are risks to the partner of either having two patients or of having to raise a child alone. And some of the concerns might be concerns for society, costs of care for the woman, costs of care for the child, and possibly even costs of care for the child for quite a long time, things like child care costs. One important point to make about considering these risks is to think about whether they're risks that you would entertain and that are sufficiently high so that you would decline to provide care in a case in which the risks came not from the woman's immediate medical condition, but, for example, from the woman's age or from some other kind of condition that doesn't make the pregnancy risky, but that might mean that the woman has a decreased lifespan so that the child might be raised without a mother. In general, people don't take those risks into account, and if they don't take those risks into account in other cases, they shouldn't take the risks into account in the case of a woman with an underlying condition that makes the pregnancy itself riskier. So what did the ASRM ethics opinion say? I think a fair way to characterize the opinion is to say that it recognizes the difficulty of these situations and that these are situations in which providers may reasonably disagree about the appropriateness of providing care. It also recognizes that there are some ways of reasoning that are not appropriate in these circumstances. So here are the basic take-home points from the ASRM ethics opinion. First, women at increased risks should be thoroughly counseled before deciding whether to undergo assisted reproduction, including information about risks. And I would also add to that a very careful discussion of what the real goals of care are. Second, providers should recognize the importance of reproductive liberty and the rights of women to make risky choices. Third, professional integrity is also a core ethical value. And these are cases in which clinicians may decide reasonably to decline to provide care on the basis of good evidence that the risks are too high. I would underscore good evidence, not just a guess. Finally, this is an area in which non-discrimination really matters. Clinicians should make decisions about whether the risks are too high on the basis of evaluation of the evidence, including consultation, not on the basis of characteristics of the patient, such as disability. Some final observations, which I'll make very quickly so we have time for questions. Clinicians may reasonably differ about these cases. Informed consent is critical and hard. So is achieving non-discrimination. And it is critically important in these cases to consider the need for consultation and making sure that there's appropriate expertise about the woman's condition brought into the mix. And with that, I'm going to turn it over to the audience for questions.
Hi, the first question I have is open to all the panelists. While it is good to talk about the lowering of risks through embryo reduction, would a mandatory policy of single embryo transfer for all patients with advanced maternal age or very advanced maternal age or complex underlying issues be appropriate? As REI specialists, we have a responsibility to our patients first, but also society, the health system, and the taxpayers who contribute to such treatment in countries with state-based funding.
Hi. Okay, so I think, of course, ideally, we should have single embryo transfers for everyone, and with the freezing technologies being so good and the majority of the embryos surviving the thaws being so excellent, and with our newfound ability to screen embryos for aneuploidy, certainly all of these factors are coming together to improve outcomes, and we'll speak towards, I think in the future, we're going to look back at what we were doing 10 years ago and saying, I can't believe we ever transferred 3 or even 2 embryos. Having said that, the question of regulating, I think, is a difficult one, because certainly some women will have lower quality embryos, and I think very much we believe in sort of reproductive liberty and choice in the U.S. And there are some situations in which women may feel that it's acceptable to take on a risk, and if that risk is considered a well thought out risk and not so high as to exclude the possibility of taking the chance of twins, I still think it's reasonable to offer. Certainly, clinical judgment is important, and the physician has every right and, in fact, a responsibility to decline to transfer multiple embryos, especially in high-risk situations. And as Neil had said, there are certainly situations in which twins is just not a good idea, and every effort should be made both to counsel patients and to decline to transfer when the risk is considered too high. So, yes, ideally we should be working towards single embryo transfer.
And I would just like to add to that, if I could, that I think it's important to keep in mind that single embryo transfer will still not be the absolute cure in these populations, because certainly in the traditional AMA population, ovulation induction is going to be a greater producer of multiple gestations than IVF, and we're seeing that certainly, as I showed, decreasing the number of higher order gestations. So I just think it's important that people understand that reduction is not a cure, and I don't want people to think that I'm advocating that since reduction is available that it's okay to go ahead and reduce after multiple gestations have been produced, because the data tell us that the risk is still not reduced to what would have happened naturally.
Yeah, and I would also add, it's Sigal, that in countries that have coverage for fertility treatment, there is a compelling, perhaps, reason for the government to mandate certain regulations. But in the U.S., when there's no reimbursement in many states, it's very difficult to say to a couple or an individual that may have a limited amount of money they can spend for fertility, and if the first cycle doesn't work, they may become, they may not have any options to become parents, to transfer only one embryo. And I think that there are very high risks, certainly, that you should avoid. But in many cases, I don't believe that you can, on the one hand, not offer some sort of benefit, and on the other hand, legislate single embryo transfer.
This question,
I would add very quickly that part of what's at stake here is considering whether there are reasonable ways to reduce risks within a highly risky situation.
Thank you. The next question is, again, for all of the panelists, or at least for Dr. Silverman and Klipstein. Do you observe women from disadvantaged socioeconomic backgrounds tending to take more, less, or similar risks?
Neil, do you want to start, or should I?
I'm not quite sure how to address that, because I personally have not seen a difference in risk acceptance based on a woman's socioeconomic background. I think that all women, regardless of socioeconomic background, warrant an appropriate explanation of risk. And my experience has been that if risk is explained in a relatively standard way, that that socioeconomic background isn't an important stratifier in explanation.
Yeah, I would agree with that. In the end, all women want healthy pregnancies, so.
Interesting.
Where there are data, it suggests that women from disadvantaged backgrounds are less likely to seek out infertility care or to be able to access it.
This question might be for Dr. Francis. What should I do if a patient doesn't want to tell her partner about the risks?
Counsel her and strongly urge her to tell, because, and part of that counseling should be talking with her about how it might actually increase her risks and decrease her ability to achieve the goals that she wants if she doesn't share the information. The second thing that's really important is to explore why she doesn't want to share the information, and to be as supportive as you possibly can in helping her to share the information.
Thank you. The next question is, what, in your opinion, should be a reasonable age upper limit for women using donor oocytes?
I'll try to address this first, and Sigal and Leslie, feel free to step in. So I think that what you saw from some of the data from Israel is that I think it's important to use age as a part of the equation, but the other part has to be what the patient's underlying medical status is. We saw in the data from Israel that 40% of women had at least one chronic medical condition who were over the age of 45, and I think that that's too many. So that there may be women who are 51 whose baseline medical condition is far better than other women who are 42. So I think that a holistic, complete medical picture really needs to come into play, but that even in women who have no pre-existing medical conditions, that once we start approaching the middle 50s, their rates of medical complications are dramatically higher, even if they have no known pre-existing conditions.
Did you have anything to add, Dr. Klipstein?
No, I agree with Neil. I think it's individualized, and the upper limit is changing as we're living healthier, and it used to be that we talk about age 40, and then we talked about age 45, and the ASRM actually committee opinions reflect that as we are talking about advanced reproductive age, and that age creeps up a little bit. But in the end, you have to look at the whole picture, the woman's health, her support system, what would happen to the children if something were to happen to her. So I don't know that you can have an absolute cutoff for every woman, because that wouldn't apply. Some women would be at higher risk at a much lower age, and vice versa. So I think you still have to take it on a case-by-case basis.
One
use your
last
clinical
question.
judgment.
Thank you. One last question came in through the chat box. Any comments about posthumous use of gametes?
It's permissible if there is evidence that that's what the person would have wanted.
Yeah, I'm assuming that this more addresses male partner who might be deceased, and I think I would echo Leslie that the controversies arise when these things are not laid out clearly prior to a pregnancy, and that's where the legal and ethical quandaries arise when there's an absence of a clear desire on the part of the deceased partner.
For further discussion on posthumous reproduction, you're welcome to visit our ASRM Ethics Committee document page, where there is a current document on that very subject. Dr. Klipstein, did you have something to add?
Nope.
Fantastic. Well, thank you all to our presenters and our attendees. This session was recorded and will be available on our website in the coming weeks. Please keep an eye out for an announcement of our next webinar topic for December. For any further questions or comments, please don't hesitate to contact me at asrm@asrm.org. Attention, Jessica. This concludes the webinar.